Hey, Section 4. I hope everyone's doing well. Week 3 is in the books, so to speak. And it was a good week. A lot of good discussion and some of the groups really got after it. I like to see that. And we'll be, just as an FYI, we will be mixing it up after this week. So I'll start on Charlie and Delta. And we'll move Kirsten and Damon to Alpha and Bravo. And you get a taste of some different things. I was able to peek in again this week. I was able to actually comment this week on some stuff on Charlie and Delta, just a few comments here and there, and just to again appreciate what you guys are doing, the good work that you're doing. And I saw a lot of good stuff. But talked about the acromioclavicular joint. We talked about proximal humeral fractures and biceps related issues, whether it be a tendinopathy or a SLAP lesion. So let's get into it. So long head of the biceps, tendon pain, differential diagnosis in the Krupp article. Some research refutes the role of, if any, of the long head of the bicep, and that was, I heard a lot of people, or there was a lot of discussion about that and its relationship to stability, both primary and secondary, and its relationship to rotator cuff tendinopathy. We just don't know in a lot of cases. Now there's more examples of tendinosis versus tendinitis. And I say, can we just stop using the term tendinitis? There are very few cases of tendinitis. There's a direct impact. We usually relate it to some acute onset of symptoms, but oftentimes we call it way too many oftentimes called things itises that have really no business to. And the only reason I harp on that is because our approach to treatment needs to change. And with that change in diagnosis and change in terminology, we can then change and reframe the patient's perspective, like why do you take NSAIDs? Why do we not just sit around and wait for it to get better, right? Because it's not an inflammatory condition, right? And so I shared with some people, and I think I've spoken about this police article, we talk about progressive loading, ice compression elevation, as opposed to rest. And rest doesn't help any kind of tendon. It really, except maybe the first couple of days, you just need to gradually work that tendon, load it to tolerance. Really, we're trying to build in tolerance. Like somebody used that term, and I was going to applaud them. Might have been Ann. Excuse me if I'm forgetting who, talking about tolerance. We're trying to build in tolerance to the tendon. The tendon at that time has poor tolerance, and we're trying to increase that tolerance. The lawn chair rehabilitative program that was given as an example is a great progression, if you will. The phases of rehabilitation, I think those are good and good kind of very basic understanding, things that you can speak to not physicians, but patients about, because I think they can appreciate that. And then lastly, the tenodesis versus tenotomies. I don't see many of these, and I'm kind of glad because I question what we're doing here. It's usually about pain, and hopefully we can get the pain under control. I have seen a couple, but I don't know. I guess I don't have a lot of experience with these, and so my skepticism probably holds, and that's just due to my lack of working knowledge. Okay, so in the next part, we're going to look at this Dodson article talking about special tests, our power and recommended in combination with subjective, or our powerful. So special tests, I made a mistake there. Special tests have fairly low power and recommended in combination with subjective information. That whole sentence I just kind of messed up. So. But bottom line is, the SLAP tests, they got a whole bunch of them, and they really have poor reliability, and I hope you just appreciate that. Now, that doesn't mean we don't use them, but what it does mean is that we understand that they have their limitations, and that until we get a better way of diagnosing this, sometimes problematic diagnosis, we need to be very careful. I want to appreciate that the protocols in this week's readings are very much surgeon-driven, and I say shame on us, because as a profession, we can't let surgeons dictate how we rehab, right? I'm not going to tell a surgeon what they need to do in regards to repairing something, and nor do I think they have any business in telling us how to rehab something. Certainly, we should be working in combination at the very most with them, because we can certainly appreciate why they did what they did. Whether that has any bearing on the outcome could definitely be called into question. As we know, when we start to make things more complicated, usually we just like to make them more complicated so that we sound better, and we could use that. That holds true even in our profession when we start to make things more complicated. Okay, so if we move on to the proximal humeral fractures, Good assessment of could assessment of functional recovery typically gets lost in the ortho literature. So a lot of people were talking about function. Well, how is it that the function is really lost and is important? Talking about early mobilization at 3 weeks and then moving on, getting that person moving again, as opposed to having them locked in for an extended period of time. Is surgery any better than non-surgery? I really think that can be called into question too. And the reason we say that is because a lot of these people who are having surgery are extremely old, they are extremely frail, they are medically complicated, and you start to throw in anesthesia, pain medications, risk of just being in the hospital. Shoot, I mean, as we know, when I used to work in the hospital, if you have no business, if you don't belong in the hospital, you need to stay far, far away, because it is not, with all of the anti-drug resistant bacteria that exist in a hospital, man, you just gotta stay away. And then that whole 5% increase in infection, a lot of people talked about that. And I think that's it's not a huge number, but it's certainly significant enough that this is obviously a concern. The Harris article, ACJ and injections, that was obviously news to some, and people really enjoyed the kind of the manual therapy aspect of it. There's really not a ton of literature on ACJ stuff. I remember hearing a really good talk that Gail Dial did as part of a fellowship, manual therapy fellowship group. Gail Dial is, if you've had the lower extremity class, he's got some really good work on NEOA. He's the leader of the fellowship program at Baylor, and he comes and sometimes will present with his fellows at EIM, and he did a really good one on ACJ mobilization manipulation a couple of years back. But there isn't a ton out there, and so you don't expect to find a lot of other articles if you were searching, because there just isn't a ton. But I want to talk about booster treatments. Booster treatments are going to start to get, I think, a little bit more play, not only because they've been shown to be beneficial with hip and knee OA, maybe here with ACJ. I think booster treatments are something that eventually we're going to look at. So some of these people with chronic pain, that in the future that will say, come back and see us in 6 months and we'll do a couple of visits, and then you'll go away and say, come back and see us in 6 months and we'll tweak your exercises, and then come back. And I think that's going to become more commonplace. The Kibler article, looking at just the activation of closed versus open chain. I think this is kind of an interesting slide. Kind of hone in on the different muscle activations for common exercise. I do think that this was interesting. So, comments. There's no real good program for eccentric training. It needed to help to get better to understand the effects. Many people commented, we need to better understand kind of strength conditioning programs. I talked about that in Alpha and Bravo groups, that is eccentric better than concentric? We don't really know. There's still a lot to be done. I think weight bearing is a great way to retrain any kind of shoulder problem. So in my opinion, weight bearing always wins. Tendon healing is all about progressive loading. And I think if you come away from anything this week is we progressively load tendons so that we're building tolerance, right? That's, in my mind, that's a big takeaway. Regional interdependent approach. I think that when we were talking about, people were talking about mobilizing ACJs, that maybe some of them has not been in their treatment paradigm. And I was talking about getting after ACJ and SCJ and CTJ and first rib, because that whole shoulder girdle, I always take a very regional approach. And I get in there and work the neck as well. And maybe some of these people who are surgical candidates could avoid surgery if we got in there, because the clavicle decompressions, the surgery rates on those are way too high. And I think we just need to do a better job of managing those people. I've talking about the post-surgical protocols. I think, again, collaboratively and guided by the evidence. I did make a comment that my guy and some people kind of cued into this, they found this helpful, so I'm going to share it. I usually think of 40 being the divider, right? You rarely see anybody with a rotator cuff tear under the age of 40, and slap lesions beyond 40 are usually more degenerative and are usually asymptomatic. So in my opinion, between 40 and 45, anybody younger, if it's going to be driven by shoulder pain, that's going to be something that you really need to be concerned about. You look at a potential slap problem. And over the age of 45, you look at potential rotator cuff problems, and not vice versa. I've had one patient who had a traumatic rotator cuff tear, and he was 33. But even the surgeon commented that was the youngest rotator cuff repair that he had seen done on a person. in his career. So nice work on the boards this week, gang. Keep it up. I always love reading your comments, and I always love the enthusiasm. I love people's ideas, people's thought processes, even if it's, maybe not directly related to a specific topic, like I bring in this or I bring in that to my treatment. I love that you share that. We can agree, we can disagree about what is available. We try to use the literature to support what we do, and if we don't use the literature, whether it's then we need to think critically about why we do what we do, and perhaps be appreciative of kind of those non-specific effects, right? And that bias and placebo, and even, we want to stay away from nocebo, but those are all very real treatment effects. So moving on, get your cats in and everybody start interacting. So cats are, I think, all but one, I think we had ready to roll, and I'm sure that person will be getting it in the matter of minutes, and perhaps is even in now as I speak. Read and comment discussions about glenohumeral joint instability is coming up, and adhesive capsulitis. We'll be talking about the different treatment options associated with this. Both of them can be tricky to treat. Reminder, don't wait until Saturday to post. Please, please, please. I think you can, for those who are posting, and especially when I'm able to interact, we can get in 3 or 4 kind of give and takes, which I hope people find add to the week. Outside of the literature, because we can go in different directions, and I do think that adds to your overall learning base. So, have any questions? Feel free to shoot me any questions that you may have. I got a couple of questions about the cats this week, and hopefully cleared that up, and know that you're not alone if you get frustrated or need some guidance in any way. I'm here for you. Hope you all have a great weekend. For those celebrating Easter, enjoy your time with your family and your Easter celebration. Otherwise, we'll see you all again at the end of week 4. We'll be at halfway point. We'll start talking about mid-quarter grades, and we'll have had the group projects under our belt. And then at the end of week 4, I will be switching up the groups, but that's more to come. And do remember that I'll be going down to Charlie and Delta this week, and Damien and Kristen, who are doing a great job, will be popping up to Alpha and Bravo. Take good care. Enjoy your weekend.